Good morning, good afternoon, good evening to all my colleagues all around the world. We are back again with our partner session going all around the world in this COVID times, and we are having the best opportunity right here for all the dental professionals to learn every aspect of dentistry, including very famous speakers and their topics. Today we have a very special guest here, Dr. Felipe Franco de Sousa. So before we start the lecture, I would like to introduce our speaker. He is DDS at Instituto Superior de Ciencias de Saúde Sul, Diploma in Clinical Periodontology from the University of Gothenburg in the year 2010-11. He also holds a certificate in plastic periodontal surgery from Complutense University Madrid in 2011. He is a professor at the post-graduation Oral Advanced Biomimetic Rehabilitation at CESPU University from 2013 to 18. Also post-graduation in Oral Implantology in CESPU University from 2015 to 16. Lecturer in several Portuguese dental events and clinical practice in oral, functional and aesthetic rehabilitation. Wow, that was a great CV of today's speaker, Dr. Philip, and I would like to welcome him aboard the Global Summit, the biggest platform right now, which is related to education of, you can say advanced dentistry and implantology. Sir, you are welcome to our foreigner platform.
Thank you very much. It's an honor. I would like to thank you for the invitation. It's an honor to be speaking a little bit of my passion, okay? And I hope everyone enjoys it as much as I enjoyed it doing it for you, okay?
Yes, sir. The topic has already been shared with much of the audience. I think they are very much interested to hear. So the topic on which Dr. Philip is going to speak today is teamwork communication, the key to success in aesthetic rehabilitation. So Dr. Philip, if I like to ask you a few, we can have some few question and answers before we start the topic for the audience.
Perfect for me.
Okay, so Dr. Philip, face and teeth have an essential place in the dominant body aesthetics. Any comments about it?
Yes, I will talk in my lecture about it a little bit.
Yes, just a brief now.
Okay, you cannot speak about teeth without the face, okay?
Yes.
And aesthetic is not symmetry, because you don't have symmetry in the nature. It's harmony, okay? And harmony with the whole face. So in your evaluation, you cannot forget the face, because you can have beautiful teeth that don't match the face of the people, okay? So it's a very important thing to assess and to be aware when you are planning the aesthetic cases, okay?
Yeah. Do you think the modern society right now is, accepting the dentofacial aesthetics, or are they coming for that as a major concern?
Yes. Nowadays, here in Portugal, Europe, it's a little bit different than the USA. Okay, but
yes.
Nowadays you see people searching dental practices to do aesthetic treatments. So. And here we have a little problem, the frontier between over-treatment or not, okay? So we are having this problem starting here in Portugal also, okay? So I'm a most classical dentist, and it's very difficult to give some advice to your patient because of in order not to pass that over treatment frontier, okay, line. But yes, answering to your question, yes, we here in Portugal the society and people are searching us for because of their appearance, the beauty of the smile, personally and professionally also. Okay.
That's very nice to hear. I think this idea of aesthetics is going worldwide right now.
Yeah.
And yes, everyone deserves a beautiful smile.
Yes, that's true.
Yeah, Dr. Philip has a good smile.
Perfect,
Okay, so Dr. Philip,
perfect imperfections.
yeah. Okay, so I just read in your topic, the heading, it says multidisciplinary approach. What stress do you want to put on this point? The word multidisciplinary when we come to talk about aesthetic rehab.
Yeah, the problem is, and I receive quite a bit of referred patients. Okay, and the
Yeah.
problem is, where's the frontier of just an aesthetic treatment and a functional treatment also? Okay, so it's important to know the frontier, because there are some patients that doesn't need just an aesthetic treatment. They need a functional treatment, and if you put them some veneers or a simple composite, it will break because everything is not functional. And I receive some patients that came with the indication of veneers, and they have to do a full mouth rehabilitation. Okay, I will talk a little bit about it. That's not the main topic. I will talk just
Okay.
about aesthetic cases. Okay.
Okay.
But when I started 8 years ago doing biomimetic dentistry, I was focused on the aesthetic part of it and not the functional
Fine.
part. And I think
Okay.
it's the way that most every dentist goes normally. Okay. And when you do aesthetic and you are doing aesthetic and you are feeling comfortable doing aesthetic treatments, you will think further. You want your treatments to be your follow-ups to be well in over the years. So you have to treat functional. And my main concern nowadays is function, because the aesthetic comes like a consequence of function. Okay, so I'm
Yes.
doing much more functional cases nowadays than just aesthetic ones. Okay, but the mainly focus,
Oh,
I'm going to focus on aesthetic. I will talk a little bit about function also. I will show.
that's great to hear. And my last, before your presentation, a last query, Doc. Are we going to talk about physiologic correction or pathologic correction as well?
No, because I'm just talking about mainly about aesthetic. Okay.
Okay.
I'm not talking about pathology. I will mainly I will talk about the workflow, my
The
workflow
workflow.
with
Okay.
my
So there is a
with,
whole, so there is a whole team behind it.
yes, I have a small practice. Okay, nowadays I have a colleague of mine helping me with the cases. Okay, because I'm having, thank God, lots of work, and it's and you have to work with a dental technician, and I don't have a dental technician in my practice. Okay, and we have to
Okay.
work with distance. So I'm going to show you all the weapons, all the tricks that we developed in 9 years of working with João, that is my dental technician. So, and
That's awesome.
we are also improving every day. Okay, and that's also a message that I want to share with everybody
Great.
at the
Great.
end. Okay?
Yeah, so audience, we just had a very nice session, a starting session with Dr. Philip, and I could hear a very nice word, weapon. So I guess it's a very nice word to use in daily dentistry. We have to use some techniques. Even I would love to use the word weapon from nowadays. What weapons do we use? So I think I should, uh, you know, ask the speaker to go on to the presentation, and let's hear his weapons and techniques for aesthetic rehabilitation. Over to you, sir, Dr. Philip.
Let's go. Okay. I'm going to start talking about this topic. We had a little introduction with Dr. Prutinder, and I just said mainly what I was going to talk about it. So let's start. In a little introduction, I came from Portugal. Portugal is the western country of Europe, near to Spain. It's this little country here at the end of Europe that has a profile like a face. And in Portugal, I came from a city that's Cascais, next to Lisbon, the capital. Okay, here it is, Cascais, and here is where I live. I would love for you to come to the city, to Portugal, to see. We have good weather, good beaches, good food, and good people. So you are all invited to come and visit us. We just talk about me. I'm mainly a clinician, okay? I'm not an academic, even though I was a professor in a postgraduate program of biomimetic dentistry at SESPO Porto University. But I'm a clinician, okay? And I do, as I told you, my primarily practice nowadays, it's oral rehabilitation and biomimetic dentistry, okay? I do some general practice yet, but I'm focusing on rehabilitation because it's my mainly cases that I have nowadays, okay? I like to start with this sentence, this genius sentence that I have present always in my life, personal and professional life. It's Einstein said that insanity is doing the same thing over and over again, expecting different results. And yes, this is, if we have to assess what we do, and we have to know that if we fail, let's change something in order not to fail again. Because if we are doing everything the same way, you are probably going to fail again. So don't be afraid of the changes, and evaluate your work in order to improve every day, and don't be afraid of the changes, okay? I have to talk also about mentors, and my mentor is Pascal Maing. In 8-9 years ago, there was a Portuguese dentist colleague of mine that started a group in Facebook for sharing dental cases, and I started to see some works of two dentists, Portuguese dentists, that took Pascal Maing IDA course in San Francisco, I think, and I was overwhelmed by the philosophy. So I didn't have any course of formation in biomimetic. I just studied his book, so I strongly recommend his book for everyone that is interested in this approach to read it, because it's a Bible. And I started to study and started to practice, to apply in my practice. So nowadays I'm very conservative in biomimetic. I apply very conservative in biomimetic dentistry. And biomimetic is this. This is nature. This is perfection. So we have to mimic what we see here, dent in an animal. So we have to use materials, we have to be conservative, and to save all these structures, okay, dental structures. Nowadays, today I'm going to talk about workflow, as I told you, and we're going to finish with some cases and explaining the cases and seeing the follow-ups of these aesthetic cases. So the thing is, you can have all the qualities required to do this kind of treatment, differentiated treatments, but if you don't have a protocol and if you don't have everything organized, you will not succeed. You will fail. This is what it's represented here in these two pictures. Okay, you have to have protocols, and I'm working in my protocol since 9 years ago when I started to work with João, my dental technician, and we are still working on it in order to improve it, to make it easy, repeatable, and predictable. Okay, that's all what all of us want in our practice. I think so. So, as I told, I don't have a lab in my clinic. It's a small practice, so we have to work with distance, and we have to communicate. And it's easy that the message could be lost in hello?
Yeah.
Be lost in. So, as I told, I don't have a lab in my clinic. It's a small practice. Everything's okay?
No, Dr. Philip, we actually see a blue screen of the presentation on when it's going live. So perhaps you can just share the presentation again.
Okay, I will do it. Just a minute. Okay.
So perhaps you can just share the presentation again.
Can you see now?
Give me a moment, please. Yeah, it's coming fine. Yeah, please proceed. You can please start from the beginning of the presentation.
Okay, no problem.
Thank you so much.
Sorry for that technical problem. So let's begin. Everything's okay now?
Yes, sir.
Can I start?
Please start.
Okay, so let's make it short. The message was sent because everybody was listening. So, as I told you, I came from Portugal. It's the Western country in Europe. This one was a profile, like a profile of a face. Okay.
Yes, sir.
So it's a beautiful country. I come from Cascais. That's near Lisbon. Here is Cascais, and this is my hometown where I live. Okay, you are all welcome to come and join us and visit. Oh, sorry. I think I lost my screen. I think I lost my screen again.
No, it's all fine.
I'm not seeing it in my Facebook. Okay, now it's fine. Okay, sorry. Everything okay now?
Yes.
Okay, let's go. So you are all invited to come to Portugal. We have good people, good weather, and good food, and nice beaches. I'm not talking again about me. This was the phrase, the quote of Einstein that I was talking about. Don't be afraid of change. Okay, you have to change something if you want to change the results. So if you are failing, you have to change what you are doing, or else you will have the same result, the same failure. Okay, so don't be afraid to change. I changed my life, my practice life 8 years ago when I started to doing biomimetic. Okay, and this is the master of biomimetic, Pascal Magne. I think everybody knows. I strongly recommend his book. Okay, so this is. I didn't take any formation, as I told you, in biomimetic dentistry. I just studied and I'm practicing now. Okay, this is what we want to save It's this structure. Nature is beautiful, and we have to preserve it mostly. So we have to use some materials that can mimic mechanically and optical this structure of the tooth. So this is, and we have to be conservative, okay? I'm going to show you my workflow, as I told you. And because if you can have all the qualities that you need, all the skills that you need to be successful in your practice, in your results, but if they are not organized, if you don't have protocols, you will fail. Okay, I can give you an example. I didn't have a photographic protocol I didn't make a photographic protocol in a paper, okay, with all the photos that I needed. I knew it by head. What do I needed to work? But every time it was missing one photo, and I have to call the patient again and do that photo in order to start planning the work. So you have to have protocols for everything, I think, in order not to fail. As I told you, we work at distance with the dental technician, so you have to communicate, and it's easy for the message to be lost in translation. So you have to have a message that's clear, simple, and direct. And nowadays, with technology, you have lots of apps and programs to facilitate your life in communicating. So use them, and abuse them. Okay, no problem with that. And this is my workflow. This is the workflow that I do for aesthetic treatments, not for functional treatments, okay? This is mainly aesthetic treatments. And this is the steps that I do in my practice, okay? The first step is data collection, okay? And second step is diagnosis and planning, normal. Afterwards, we will do an mockup. My technician, João, will do an mockup, and then we will try it in the mouth in the mockup. And if everything's okay, we will advance to preparation, impression, and provisionals. Afterwards, João will do the lab procedures, and we will do an appointment to make the adhesion of the restorations. And finally, last but not least, the final evaluation. And here, it's a very important step in the workflow, because I will show a case that exemplifies this. I learned in the years that I'm practicing aesthetic dentistry mainly that you are not working in aesthetic, you are not working for you, you are working for the patient. And you have to manage expectations. And if the patient's expectations are here and you give him this, he will be thrilled and very happy about it. But if you are not happy because you know you can give him more, but you just give her more than his expectations, that difference that you can give the patient will not be valued by him. And you can transform a good experience in a bad experience for the patient. So the final evaluation goes in that sense. Even though you are not 100% happy about your treatment, you will evaluate the final outcome, and you will discuss with your technician. That's what we do in order to be better in the next, or do better in the next case. Okay. So the first appointment that I do with the patient, as I told you, I receive some referred patients nowadays, referred from other patients and referred from colleagues. So the first appointment that I do, I just talk with the patient, okay? It's easy to receive a referred patient because the patient comes with some confidence in you, because his doctor said that you were the best to treat his case. So the patient arrives with confidence, and you have to create empathy with the patient. Okay, it's easier than you having a first appointment that the patient doesn't know you, and you have to gain his confidence. So the first appointment is to assess the insatisfaction of the patient, and I will have to empathize with him and gain his confidence. So what do? I show similar cases to his case, the before and after, in order to gain his trust. And in the next appointment, I do the data collection. And the data collection is, I do directly a shade identification. Why? Because normally, if you do the shade identification in the appointment that you are going to prep the teeth, normally I would forget about it, okay? And you prep the teeth, and the teeth are dehydrated. So you cannot take a shade identification when teeth are dehydrated, okay? Because the values rises, and the value of the color rises, and they become more opaque. So you have, I inserted the shade identification in my primarily photographic protocol, and that's how I do not fail with this step, okay? Then I do some photographs and some video, and then I do some impressions. Yeah, nowadays we have the digital, and the digital is perfect for some cases, okay, and can facilitate your life. But I have a small practice, and business-wise, it's not interesting because the technology is still very expensive, okay? And as you will see, in the anterior area, we work mainly with feldespatic ceramic stratified. So we do not do milling restorations, okay? In the anterior area. Even crowns, we do jackets, feldespatic jackets, and as I will show you further on. So in the shade identification, it's important to do this basic image editing, because you have to assess the 3 dimensions of color. As you know, the color has 3 dimensions, has hue, value, and chroma or saturation. So the first photo is to assess hue, the second photo, black and white, is to assess value, and the third photo, I will give her a saturation of 45% in Photoshop. It's a value that me and João assessed that was sufficient to have an evaluation of saturation of the teeth regarding the shade guide. So we always do 45%, okay? And then this was my idea some years ago. You can see in the left photo that it was a crown in the 21, teeth 21. And normally, just focus on the left photo. Normally, the technician will look at this photo. He will see the characteristics of the 11, and he will have to flip what he sees in the 11 in his mind in order to make the stratification of the 21 tooth. Okay, so what do I remember? Yeah, in Photoshop I could cut the 11, flip it horizontally, and put it underneath in front of the 21 tooth, so we can assess dimensions. And when he looks at the photo, he just has to make a direct copy of it. He doesn't have to flip it in his mind. That's the upper right photo. And in the lower right photo, this is the contrast augmented, because you can see the incisal. It's a good photo. It's a good editing to see the incisal halo, all the characteristics. Okay, it will pop them up. And my photographic protocol, we have before that we also do some custom shade guides. Okay, we did it years ago, because mainly the shade guides of the ceramics are in acrylic resin. Okay, they are not ceramic, so it will be a difference in the color characteristics. And Smileline has this kit of my shade guide. It's perfect to do ceramic guides. And we know also that when we cook the same ceramic in different ovens, we can have different behavior of the color also. So it's important for having this kind of shades guide because made by the oven that he's doing his work on. So it's a very nice kit, and you have this very good presentation, and you will have the editing that I told you earlier, okay, to assess the 3 dimensions of color. We have also polarization. Nowadays we have this little kit by Smileline that you can assess directly with your eyes in the patient mouth to shade identification, and you have polar eyes. We are starting to work with the ELAB procedure by Sasha Heim. It's a very interesting procedure, and we use polarizing photos also. And this is the photographic protocol just for aesthetic evaluation. This is what me and João designed that we needed to work and to plan a case, okay? So in every patient, I do this photographic protocol for aesthetic evaluation and a little video in order to assess the dynamic of the lips with the smile. For functional evaluation, I do a little more photos to assess other details. We are not talking about function today, but I have also a protocol that I do every time, and a video also, okay? The video, you can do it with your DSLR camera that I don't have in the lower, I don't know why, and with your iPhone, okay? And the impressions, I do a double, 2-time technique. So I do a putty first, I space the putty, and then I do a light in 2 times. Okay, it's the most detailed impression that you can have. Okay, and then you can do a face bow. Okay, but nowadays I don't use the face bow. I use the plane finder by Zirkonzen. I don't know if you know about this. I will talk very shortly about it because we can have a lecture of 1 hour just about plane finder and face bows, okay? But summarizing it, the Zirkonzen plane finder, it reduces the problems that we have with face bow nowadays. And what problems do we have with face bow? I will assess some major issues, because when you are collecting data that you will put your hands in it, like the face bow, you can induce some error, okay? Because we know that if you make a face bow in the same operator in the same patient 5 times, you will have 5 different registrations, okay? Yeah, you can say, yeah, there's a little bit discrepancy between them, okay? Yeah, it can be true, but you are inducing an error in your data collection, okay? The plane finder, what the plane finder does. And another thing is you register the position of the maxillary in regard of an intracranial plane, okay? With the face bow, okay? And with the plane finder, you will make a maxillary registration in the patient in the natural head position, okay, in regards of the 0 plane, parallel to the floor, okay. This mirror mimetizes the horizontal line. The patient position himself. I'm not touching the patient, okay. You will do these 2 points in the 2 sides of the cheeks of the patient, and she will step out and step in 3-4 times, and you will see that she's always in the same position, okay? Then we will have, this is very, very nice, because why? Because even with face bow, I have some issues with cantings and tilts in the middle line. And we know that a deviation of the middle line till 4 millimeters is not perceived by a common person. You have the example of Tom Cruise. You don't think that Tom Cruise is not sexy because of his midline deviation. But a tilt, we know from studies that the tilt, mostly everybody can look that there's a problem. There's a how do I say, a discrepancy in his smile. There's no harmony in it. And with the fishbowl, what are our mainly guides? It's the bipupillary line, and we know that nobody is symmetric. Okay, so you have deviation of the bipupillary line, like this patient here, and I could show dozens of patients that has this problem. Okay, this it's not a problem. It's a characteristic. Okay, because of the facial growth patterns. Okay, and what was the problem? I had some tilts and some cantings. Yeah, you can correct them in the wax up, in the mock-up stage. But why do I have to have another step if I can eliminate that problem? So even for these cases, it's very nice to use the plane finder. Okay, as you can see here, the deviation of the bipupillary line in regards of the natural head position of the patient and the zero plane. Okay. Then you take a registration of the upper jaw, the upper maxillary, and you will measure the camper plane. Okay, we know that in 80% of the patients, the camper plane corresponds to the functional plane. Okay, and this particular device can measure the left and right camper plane. Okay, so you can do your functional rehabilitation respecting that difference. Okay, with when you cast mounted this in the PS1, and this is what we send to the lab. You don't send the face bow, you don't send the knee of the face bow like in Artex, because in the transportation you can induce an error also. If it falls in the floor, it can change the position, so it will arrive to the technician in the wrong position, and he will do a wrong cast mounted in the articulator. So, and I made the experience in the same patient with two systems. Here's the BioArt. It's a Brazilian face bow system, face bow and articulator. That the reference plane is the Frankfurt in this case. Okay, and I did a mount cast in the same patient with the Artex, and the reference plane of the Artex is not the camper plane, as many people think. It's 5 centimeters underneath the glabella. So it depends on the anatomic glabella of the patient. Okay, you can have camper. This case was camper. It matches camper. Okay, so, and you can see I mounted just the upper maxillary jaw, and you can see the difference in the inclinations. Okay, and you can see the Artex is more inclinated. Okay, more stiff the angle than in the PS1. It's the middle one, and the right one, sorry, it's the BioArt. So Artex left, center PS1, and right BioArt. Okay, and in the frontal plane you can see this. Look what we can find. Okay, you have a tilted model in the BioArt in the right, to the right. You have a tilted model to the right. You have almost an horizontal model in the center in the PS1. And in the Artex, you have a tilted to the left, to the right, sorry, the tilted to the left in BioArt and the tilted to the right in Artex. Okay, so you can see the discrepancies here, and they are not so little like this. Okay, and imagine that you have these three patients, and these three patients, you have the zero plane, and this three patient has different inclinations of the camper plane. Okay, if your face bow, the reference plane is camper, imagine. Okay, when you are going to cast mount the model in your articulator, the upper arm of the articulator is what? The upper arm of the articulator is, hello? Everything's okay? Okay. Yep. The upper arm of the articulator is the zero plane. Okay, so If the reference is Camper, see in the how you will see the rotation in the end patients, the right and the left. The center one, no big deal, because her Camper is almost 0, okay, in inclination. But when you cast the model, look how the patient will be in your articulator, okay? The right one will be like this. So when your technician is looking at your articulator, he will see an upper, the maxillary of the patient like this. It's much easier to work when you look to the articulator in the natural head position. And let's see with the Frankfurt. It's the reverse, okay? You will see the patient like this in the articulator, okay? So we have lots of other details to discuss about it, but that's not the point, okay? So this is how I manage all the information, okay? I do a keynote, and then I share a PDF with high resolution with my technician. And it always the same organization, okay? And has when you are treating the patient, okay, you will see, you can add some information, okay? You will see here I have some preps in the lower right slide. I have some preps for veneers, and I'm taking the color of the preparation. Hello? And this is another example that I'm adding information as long as the treatment advances, okay? Sorry, this is the way that I speak to my patient also, okay? How that I assess the planning with him, that I discuss the planning and the budget appointment, okay? I will show him this information also with this organization. The next step is to plan, okay? And in the aesthetic planning, we are the first thing that's very important is to assess the position of the incisal wedge, okay? Even in functional treatments, okay? So you have to assess the height of the incisal wedge and the projection of the incisal wedge. This is the most important thing to do, okay? And then you can work with dental proportions, okay? So we know from the literature that incisal edge height will vary between men and women, and with age. We tend to lose incisal display with the age because of the incompetence of the lips muscles, okay? In gravity, you have the lip more down, okay? In men, it's 0.5 to 2 millimeters. In women, is 2 to 4.5 millimeters, okay? And then we have to assess also the projection. And what do we know? How do we assess this? With phonetic tests. We know that the incisal wedge has to rest when you do the F words in the division of the labial mucosa and epithelial mucosa, okay? So you have to assess also the projection. And afterwards, we will work with dental proportions, okay? What do we know? We have some guidelines. And the main advantage of João is that I think he's perfect in form, okay? In assessing the form, the right form to the face, as we talked earlier in the introduction, okay? And yeah, we are not strict with form. I do not. The form issue is João that decides, okay? I just give some pointers about dental proportions, and we have guidelines for that. We know that the central incisor is more or less 10 millimeters. It can depend, it can vary. And the dental proportion, the pleasant dental proportion is 80%. Height versus width. What does that mean? This means that to a 10 millimeter central incisor, you have to have 8 millimeters of width, okay? We know also that the width of the lateral incisor, it's 2 millimeters less than the central, and the canine is 1 millimeter less. Okay, so then I will assess gingival levels, because you can work with dental proportions in 3 ways. Okay, you can lower, to augmentate the height of the tooth, you can lower the incisal wedge, or you can lower the incisal wedge and make a crown lengthening, or you can just do a crown lengthening. So you have to assess this in the planning. Okay, and let's talk a little bit about digital smile design. Okay, so I use it, I like it to communicate with the lab. Okay, to communicate with the patient, I don't need that, because in the first appointment, as you remember, I prefer to show before and after cases. Okay, but to communicate with the dental lab, it's perfect, because you can see here with the basic digital smile design, I can point some measures to the dental technician to work with. So it's perfect for that. Perfect. Okay, and I love it. But nowadays, because I work since 9 years with João, it's not as often as I do a digital smile design with these characteristics for him. He knows what I like. He knows he knows what normally functions with the patient. So I'm not doing nowadays much digital smile design. It's perfect to, in this case, to plan crown lengthenings. Okay, because nowadays you have digital. Okay, that you can do and digital an index. Okay, you can do a guide, a surgical guide, perfect to do your bone surgery and your gingivectomy. Okay, but digital smile design also, it's perfect to do that, to doing so and to planning. Okay, and then he will do wax up. I don't have oral scanner, but João works with Zircon-Zen system modelier, so he will scan the model and he will do a digital wax up. Okay, and then he will print a 3D model, and then I will do my index in with that 3D model. Okay, so basically this is what he does. We are working since 4 or 5 years like this, 4 to 5 years like with this. It's a partially digital workflow. Okay, and nowadays we can also do a 3D scanning of the face with an app, the phone app. Okay, so you can also send a digital a 3D scanning of the face of the patient done with a simple iPhone or a phone, Samsung. Afterwards, we will do the mock-up. And the mock-up, we will assess the form, the proportions, and how it fits in the face, as we talked about in the introduction. It's very important. It's very important to see the whole picture. Okay, not to focus on teeth. When I started, I was obsessed about symmetry and obsessed with details like angle lines, incisal, small details of teeth, and not the big picture. But the most important is aesthetic is not symmetry. You don't have symmetry in nature, as I told you. You have to have harmony. Okay, so that's what we search when we do aesthetic treatments. When I do aesthetic treatments, is harmony. Okay, and we will do the mock-up evaluation. And in the mock-up evaluation, we will have 3 options. Okay, 3 situations. Okay, the first situation, you do the mock-up, everything's okay, you like it, you take a picture of it, some photos, and you share with your lab. Okay, or you can you do the mock-up, you have small details that you want to change. So I can photograph it, I can send it, I can do a keynote. Sorry, because I don't know why the images are not appearing. I can do a little keynote with the changes, and then I will send to the technician, or I can do I do the mock-up. I have lots of changes that I want to do. It's better to do those changes in the mouth, grinding or adding material, okay, and doing an impression of it, taking some photos and sending to the lab. In the first two options, I will advance without making another mock-up to preps and impressions and provisionals, okay? In the last option, I will do another mock-up after João makes the changes in order to assess if everything's okay. I do not advance to preparations and impressions, okay? And this is the keynote that I was talking about. You have to turn, sorry, it's in Portuguese. You have to turn the information visually, okay? And you have colors, you have keynote. You can do this in the keynote with colors, with arrows, because it's not the same thing that you fill a lab sheet, okay? Or that you talk in the phone about it. The message will be lost in translation. This way, it's impossible to lose information with this kind of communication, okay? So this is what I do in my daily basis, okay? And then we will advance to prep, impression, and provisionals, okay? In this philosophy, in this area, it's very important to work with augmentations. I bought these loops 16 years ago. I was formed. I had my degree in 2002, 19 years ago. So 3 years later, I had to buy some loops, and this is the ones that I work since then. Okay, and I do my preps with multiplier handpiece. Okay, and with yellow and red burrs. Okay, so let's talk about a little bit about preparation. You have to know that we are working with 0.2, 0.3 millimeters, 0.4 millimeters veneers. We can do that nowadays, okay? If we have the color of the substrate of the tooth that's favorable, okay? So, and you have to know that in biomimetic dentistry, the insertion of the veneer is not vertical like in classic prosthodontics, it's horizontal. So you have to make the expulsivity of the tooth, the prep, to buckle. So that's what you are seeing in a small video that I could give a lecture of 2 hours just about preparation. So mainly I start with the incisal preparation, okay? You see that the burr is with an inclination to the buccal side. The reverse inclination when classical prosthodontic, because the insertion is horizontal. I will do some indexes, and I will control my prep with the index all the time. I will see where needs to be prepared. And the next step is preparing the margin, okay? I will talk a little bit after the video about the margins. So, and you have to respect the tooth anatomy, the inclinations of the tooth. And here it's the big deal and the big change. You have to give some expulsivity to buccal. That's why we are working with the burr with this inclination. So here you can see I have the space needed to my veneers, okay? Afterwards, you have to finish with some Soflex disc in order to round all angles. Internal angles in ceramic have to be rounded because it will give you some tension, and you can induce cracks and failure, cohesive failure of the material. And this is the aspect of these preps. Okay, marginal preparation. Nowadays, you will hear that you don't do chamfers in veneers because the medium thickness of the enamel in the margin is 0.4 millimeters. If you do a 0.5 chamfer, okay, like we did in the early days with veneers, you will expose dentin. And if you expose dentin, you know that the adhesion to dentin, it's not stable. The forces of adhesion are not stable in time because dentin is organic, and you have degradation of collagen, and you will lose adhesion force with time. So we want to preserve the enamel, okay? So that didn't make sense to me. And in Quintessence KDT 2016, 17, I think, there was a paper by Vitor Clavijo. It's a Brazilian, much talented dentist. He has perfect cases, but he was mentioning that you have to avoid chamfers in the cervical area. That didn't make sense to me, so I searched in the literature and I found 3 or 4 studies about that, and the study that he mentioned in his bibliography of his paper. Okay, and see, I read them, and the sample of the studies were 10 teeth. They did cuts in 10 teeth, and they concluded that the medium width of the enamel in the margin was 0.4 millimeters. That doesn't make sense. And in the studies, I couldn't understand where were they measuring it. They didn't take in consideration the age of the tooth. Okay, they didn't take in consideration measuring 1 millimeter, 2 millimeters, and 3 millimeters above the enamel cement junction. Okay, because you have sulcus that has 1, 2, or 3 millimeters. Okay, so if you are at 3 millimeters in a young tooth, you wouldn't have 0.4 thickness of enamel. Okay, so you have to assess the case. You have to see, and I don't like always and never in dentistry. Okay, so I'm conservative, but I do some light chamfers or a little scratch in the margin area in order to make João identify the limit of the veneer. Okay, so this is an example of a lower preps. You have IDS in the 31. This is just three. I will show the case. It's the last case that I will show you. And you have IDS, immediate dentin sealing, in the incisal area because all dentin was sealed. Okay, I'm not talking about IDS. Pascal Magne gave a lecture some days ago about IDS. There was 1 hour and 40 minutes. So we have lots to talk about this issue. This is another example of preps. Okay, I don't do chamfer, but I will remove the aprismatic enamel with the burr and scratch the margin. Okay, this is another example of a case of a colleague of ours that I treated, and I have the provisional stage of this case. And here is an example of a light chamfer that I didn't expose dentin. So it depends on the case. You have to assess it in order to decide what you are going to do, because there are advantages and disadvantages of doing the chamfer. Okay, and mostly important, you have to do some the photos of preparation with some shade guides. Okay, because your technician has to know what is underneath the ceramic in order to disguise a more dark substrate. Okay, and provisionals, I do a spot etch technique in the center of the tooth, as shown in the video. I use this Optibond FEL adhesive. Okay, so in this stage, I'll do a spot etch in the enamel. I put a little bit of the adhesive of the bottle of the adhesive of the Optibond FEL, and then I use a bisacrylic, okay, resin like ProTemp or Structure, okay, with an index. So you photopolymerize the adhesive, then you applied a little bit of a bisacrylic in the mouth and in the index, and then you will charge it in the mouth, okay? You let it set, then you remove the excesses, and then you remove the excesses with a 12th blade, okay? Carefully. This is the aspect of another case provisional, okay? And then we do the impression and we send it to the lab. And João will do some refractory dyes in a Geller model, and he will stratify ceramic. As I told you, we just like feldespatic ceramic in the anterior region. Yeah, you have the silicate. Yeah, you can mill feldespatic and do a cutback and just stratify the incisal edge. Yeah, you can do that, but it's not the same thing. Yeah, we tried it. The silicate, it's a material that is very beautiful in the photos, but in natural light, I do not like it. I'm not saying it that there aren't lab technicians that dominates the material, but João doesn't. I don't like the results, so that's what we use. Then we'll have the adhesion appointment, and the protocol is the MIND protocol with some updates that I will show a video of. Okay, so the first thing, we will remove the provisional with a curette, and we have to be careful to remove also the spot edge adhesive in order not to influence the fitting of the veneer. Then we do a fitting, a try-in. Okay, everything's okay. We will do rubber dam isolation. I like a very wide rubber dam isolation. I like to work with space. This is just a central incisor that we made to this patient. Then we'll put the clamp in the tooth that we are going to glue the veneer. We will try the fitting if the clamp doesn't interfere with the fitting. This is a tip by a Portuguese colleague of ours, João Desport. You can do a pattern resin and put in the tip of a microbrush and stick the veneer there to do the prepping. This is feldespatic, so it's 9% hydrofluoridic acid, 19 seconds. It depends on the ceramic. You have different protocols of etching it. Okay, so be careful. I could tell you what's the difference later on. And we will stay with this white spot area. It's the ceramic matrix that rests of ceramic matrix. So we will have to remove it with orthophosphoric acid. With a microbrush, rub it during 1 minute. Again, afterwards, we'll do an ultrasonic bath with alcohol, 96%. We will do 3 minutes in an ultrasonic bath. Then we will apply silane. Silane is to give a chemical bond between the methyl group of the methyl methacrylate in the resin and the silica present in the ceramic matrix. Afterwards, we will have to activate the silane with heat. You can do it with an air blower during 2 minutes or in an oven 100 degrees 1 minute. And then you can apply the adhesive of the OptiBond FL. And you will storage in the shield. Then we will prep the tooth. So we'll put some metal matrix to protect the other tooth, and we'll sandblast it with courgette. Afterwards, in order to clean it and to activate any IDS that we have in resin, afterwards we will do an orthophosphoric acid treatment, 30 seconds, and rinse it, clean it, and apply the adhesive of the OptiBond FL. Afterwards, I will do the adhesion with composite enamel, heated composite, HDR enamel, eye enamel dentins, okay? Remove the excesses. Air blocking, oxygen blocking, photopolymerize it again, and remove the excess with a 12 blade. And this is carefully remove the excess, all the excesses. We could talk also 2 hours about the protocol, just of this protocol. And this is the how does it has to look. You can't see the transition, okay? And the final evaluation, okay? Final evaluation is the most important part, as I told you. So we have to, even though we have to always try to be better. So we will evaluate everything, and I will talk with João, my technician, and we will discuss the case, what could we be done better, and we will try it in the next case. So now I'm going to show you some clinical cases. This is my first case of veneers, 7 years ago, I think, and it's my cousin, and she had orthodontic treatment, and they left her the 11 like this. So she was not satisfied, and we planned to make a veneer, one veneer. Okay, so my first case was the most difficult thing to do. It's one incisor, central incisor. Okay, so I just removed the composite that she had in the mesial side of the tooth, and I just rounded the angles. So it's mainly a non-prep veneer, okay? We have the space to do a veneer. And we did 10 try-ins, not because of the form or the color, but also because it was João's first case of biomimetic veneers, okay? So he was having some problems with the refractory material. In the last burn of the ceramic, the veneers were cracking. So that's why we made so much try-ins also, okay? So this is the final result. You can see that she grinds a little bit. She's a grinder in the 12 and in the incisal wedge of the 21. Every patient that I treat has in the final a splint, okay, a night guard, whatever, to protect the teeth. But you know that the compliance of the patients are not that good. So this is the final result. She was very happy. And 7 years later, this is what we have. She thought that the 11 has extruded, but you can see that she grind the incisal wedge of the 21, as I'm going to show you, okay? See this line of fracture, this enamel line of fracture? It's smaller, and she doesn't have also those marks in the incisal wedge, and you can see in the distal aspect of the tooth, it's smaller also. So she didn't use the splint, never, and she grinded the teeth. So this is how she is in these days, this year. I took this picture. So she's happy, but we are going to see what we can do. This is the proof of that adhesion works, because when you work with aesthetic, you work with self-esteem of the patient. And this patient was 20-ish when she approached me. She went to the practice not referred by anyone, and obviously she was not happy. This is a photo of her in a wedding. She gave it to me, and she wasn't happy with this situation. She cried in my first appointment. So her self-esteem was low. And when I make these photos, and I remove all the composite, and this is what I had. So if I'm going to do a 360 crown, full crown here, all the enamel will disappear because it's a thin layer of enamel, okay? So I will stay with just the root, okay? this is, you can see by transparency the blue of the rubber dam. Okay, so this is just enamel. So I plan to do a veneer here, some veneers here. Okay, so I do a pre-endo restoration. Okay, at the color of the teeth at that point. We redid the endodontic treatment. I'm not sure if it was me or a colleague. I don't remember. Probably it was me because I did some endodontics. Nowadays I don't remember the last endodontic that I did. I did an internal bleaching of the tooth and remade the restoration at the color of the bleaching. Okay, the result of the bleaching. So when we are working with thin veneers, okay, in the biomimetic way, when we are preserving enamel, we have to have substrate. The dental substrate has to be favorable in color. So I use a lot of internal bleaching in my practice, okay, in order to achieve that. So now we can do a veneer, okay? And this were the preps. And even though these preps were a little more aggressive than I do nowadays, I preserved all the enamel, as you can see in the 11, okay? And look at the space that I give João to work with. Nowadays, he's lucky to have 0.5, 0.4 millimeters. He's always complaining, okay? But you can take the materials to their limit in terms of thickness, okay? So this is the final result. And when I show her with the mirror the final result, she cried also in the last appointment. So she was very happy. And this is the final result. And this is a 6-year follow-up. And it didn't break as you would expect it. And I just had a thinner layer. So adhesive procedure, and you will hear Pascal Magne said that because I attended to his lecture about IDS the other day, and he was focusing on it. Adhesion works, but it's very operated sensitive technique. You cannot fail, okay, in the procedures, okay? So you can see she has a little recession in the 22, but she's still happy with it, okay? This is another case, central incisor with trauma, endodontic treatment, and darker 11, okay? So treatment plan is the same. I will do a re-endo. I don't remember if we did a re-endo in this case, but I will do an internal bleaching, as you can see. And afterwards, here are the preparations, and you can see I didn't make a chamfer, okay? And these are the fitting after rubber dam isolation, and you can see it's a perfect fitting, even though we didn't make a chamfer, okay? These are the preps sandblasted after sandblasting, and this is the final result. As you can see, it works in the face, okay? This is 2017, and this is the follow-up, 2020. He's a grinder also, and we made him a splint, and look, he grinded a little bit of the incisal wedge of the 11, okay? But still doing good and still happy, okay? I'm always reinforcing that I have to use the splint, but patients are very complicated sometimes, okay? This is this was the one that I showed you, the adhesion procedure. It was a central incisor. This guy was pretty funny. He was a hairdresser, a very picky hairdresser. He had a composite veneer that he didn't like it because he said that the photos, he can notice that it's different, and he wanted to do a veneer, and so on and so on. And I was joking in the photo shoot, and I told him, now do a tiger position, and he made the tiger position, and that's it. So he's funny. And this is the case. He suffered trauma. So this is the composite veneer. Not so bad at all, in my opinion, but he wanted to change it. So he had a fracture of the incisal wedge of the 11. This is the prep. We have the space needed to do a veneer. You can see that I made a light chamfer, and this is the final result after and this one I have to congratulate João, because it was the first one that we made. It was pretty nice, so he was very happy. Okay, this is the final result, and this is the final photo with the tiger move also. Okay, he was very happy. This guy, I was filming the appointment of adhesion, so when and the display of the camera was flipped, so he would see what I was doing. So when I made the try-in without rubber dam, and he saw it in the screen, he was yelling, "Oh God, thank you so much, because I prayed a lot for God to inspire your technician." So he was a pretty funny guy. This case is another one. This patient was not happy with her smile. Figure that out. She has non-carious lesions in the cervical area of the teeth, and this was the initial photo. Okay, so we plan to do some veneers, and some. This is the mock-up. She was happy about it. I was so too. So these were the preparations with the IDS, and you can see that she has a crown, a metallic ceramic crown in the 24. I don't do crowns and veneers in the same time, okay? Because it's very difficult to detect to João to manage the color of a thin restoration and a thick restoration. So normally we do the veneers first, and then we permit the veneers to hydratate, and after hydration we will do a matching shade identification, and we will do the crown in the second stage. Okay, yeah, we tried to do it in one stage and it didn't went well. So with this protocol, it works. So that's what we do. So these are the veneers after adhesion, 15 days or 1 month after adhesion, I don't remember. And nowadays, I'm a vertical fan of preparation in full crowns, okay? And there are two types of, because of the periodontal behavior. I will show you some cases. I do vertical preparation, verti-prep, and BOPT, biological oriented preparation technique by Inácio Loy. It's perfect for endodontic teeth. It's a technique that me and a colleague and João, my technician, give a course in Portugal of 2 days. So I could not speak in detail about it, but it works very well. And I will show you a case and a follow-up of a case, okay? So I transform a chamfer in vertical, like in this image, okay? And because nowadays we have materials that permit us to do this kind of treatment aesthetically, okay? Because it has to end in 0, okay? And with PFMs, okay, you couldn't finish in 0 with metal, opaque, and ceramic. You had to have metal just to finish in 0. Yeah, we do. We have been doing this for Linde in his book has some cases of vertical preparations with metal in the finishing line of the crowns, but it's not aesthetic, okay? So nowadays we have zirconia, we have the silicate, that we can do it monolithic and finishing with 0, and I'm doing feldespatic jackets in this kind of adhesed, glued to the teeth with adhesion protocol of the veneers also, and feldespatic jackets, okay? So I will show you a case further on. So this is a vertical preparation with a crown, and the periodontal response is perfect, okay? I'm very pleased with the results of vertical preparation and BOPT also. And this is the final result. she was very happy about it, and this is 4-year follow-up. Okay, so it's going good, and she's also happy. This is another case of a patient of mine. She were referred to me by another patient that were referred to me by a colleague. And in that patient, I didn't do the treatment. It was orthodontic treatment to do, not veneers. And he was a friend of this patient, and he referred her to me because I showed him some cases. Okay. That's the power of showing before and after cases. Okay. So they made her some veneers in the central incisors and one crown in the 22. Okay, so she was not happy. A veneer has fell off. They glued it again, and she was not comfortable. You can see there's clearly a biologic width invasion, and you can see she was not happy. Her self-esteem was pretty low. She was a scary patient because of all the experience. Yeah, it wasn't in a good place when she came because of her teeth. So we decided, and afterward, the day that I was going to remove these veneers, she had this information. So she was very, very, very unhappy with it. So when I removed the veneers, I encountered this. This is what they did to her to do some veneers or so. This is not biomimetic dentistry, okay? They removed all the enamel of the teeth, okay? They were not conservative. They were pretty damn aggressive, okay? And as you can see, the thickness of the preparation is, I don't need this thickness with this substrate to do crowns, okay? So what I did in this case? I put some composite because I didn't need that thickness of preparation, and I transformed. I couldn't make some veneers in this case, so I told her, and we did some crowns, okay, some vertical preparation crowns, and a BOPT in the 12th, okay. So this is the provisionals and a gingivectomy that I made, okay. This is after 15 days, I think so. So the inflammation was better, okay. And we also decided to do veneers from 14 to 24 because of the volume of the buccal corridor, okay. So these are the preparations for the veneers and the preparations for the vertical preparations of the crowns, okay. I do not make crowns and veneers in the same stage, so these are the veneers after adhesion, 15 days after adhesion, and this is the provisional crowns. You see that we have still a little inflammation, okay? So I learned that in these cases, I'm doing 2 sets of provisionals, okay? One that is made in the day when I do the preps, okay? And the other one, I make an impression, and they send me a PMMA provisional, but I don't have to do nothing, and it's perfectly polished in order to that gum to heal, okay? So I will, after hydratation of the veneers, I will assess the color, okay? And here's the ELAB procedure, also polarizing photos with the ELAB by Sasha Heim, and the provisional crowns were the first ones yet here also, and a little inflammation, and I changed them. These are the new ones, and you see that the inflammation is gone, okay? So this is the final result, okay? Look at the health of the gums, okay? Look at that. And João made a exceptional work here with the stratification, okay? Look at that. So we went from this to this, okay? And this is the image of the right is the vertical preparation in the central incisors, okay? And you can see that there's no structure the jacket. It's a feldespatic jacket with adhesion. Some people here in Portugal were very preoccupied about the excesses, because you cannot assess them infragingivally like we can assess them supragingivally prepares or in veneers. Okay, so there's no excesses, you can take them off also. And in the right you can see that's a BOPT prep. What's the difference? It's that the preparation is from the bone. Okay, you have some biological issues with the fibers and the stability and the thickness of the periodon of the biotype of the patient, that I would love to speak about it, but it will be a day of lecture. Okay, and see the health of that gum. Okay, and this is a 2-year follow-up. I called her the other day and she was very how do you say it, she came immediately. Okay, to take the follow-up photos. Okay, and this is the perfect case. Look at the health of the gums. Okay, the stability of the health of the gums, and this is the perfect, we went from this to this. This is the perfect example that what I was talking about, the expectation of the patient. Of course, that we could do a little better if we did a crown lengthening of the central incisors. Okay, yeah, it could be better. Yeah, but I overachieved her expectations. She was a scary patient. She heard when she heard the word surgery, she would not want to do it. So that's what we achieved. She's very, very, very happy with it. But yeah, we could do it better. But she will not value that difference. Okay, for her. So this is a perfect example of what I was talking about. This is a functional case. I'm not talking about function, but I will show you. This is a heavy grinder, as you can see. She has the anterior rotation of the mandible and an edge-to-edge relation in the central incisors, okay, because of the grinding. And I'm not a good brusher, okay. She's a friend of my mother's, so she's a very easy person. I always nag her about oral hygiene. Every patient of mine I nag about oral hygiene, and she says always, okay, I will do it, and she doesn't. So very difficult to manage, but this is the mock-up with a injection technique with a transparent index, injecting flowable composite through a hole that you do till the incisal wedge. It's a more aesthetic mock-up than a bisacrylic one. These are the preps, okay. Functional cases, I validate always with provisional in mouth the function and the adaptation of it. I do the protocol by Udo Plaster, the developer of Plant Finder, and the patient will remain with adhesive provisionals, added provisionals. I don't prep teeth to do the provisionals, okay? I do provisional overlays and provisional veneers that are glued to the teeth. And she had a little inflammation because they stay 1 month, 2, 3, or 4 months with the provisional in order to validate function, okay? Then I will assess by areas. I will change an area, I will take off the provisionals, I will do the definitive, the preps, the impressions, and the definitives. Then I will go to another area. So that's because appointments of with this protocol, I do appointments of half a day, afternoons, okay? If you stay 1 day with the patient, everyone who stays 1 day with the patient working, and I did it, okay? At the end, we wanted to kill each other. So it's very hard, it's very tiring for both, for me and for the patient. So that's the protocol we are using. We remove bisections and provisionals, okay? This is the final result of the veneers. And this is the final result of we did DVO augmentation of vertical dimension. Okay, so and we went from this to this. She's very, very happy, as you can see. And this is a 2 years follow-up. Look at with the oral hygiene, I lost a papilla. And I was nagging her and every recall appointment, but she said, always says, yeah, I will do it. She doesn't. Okay. This is the last photos in the COVID pandemic. And this is the final result, okay, 2 years later. This is also a functional. It's a friend of my partner's practice partner of her mother, and he was a very nice person. But here we have some limitations with this. She has a baby teeth in the 63, and she has an impacted canine, okay, in the palate, and she has some malpositioning in the incisal, inferior incisal area. So what do I plan for her? I planned extraction of the baby teeth, traction with orthodontic braces, 2 years of orthodontic braces. I don't do orthodontic, my partner does it, but she refuses permanently. She didn't want to do the surgery, she didn't want to do orthodontics. So I gave her 2 options. Okay, the first one, the ideal one, and then the other one was she has the root of the baby teeth. So I have some cases that I did post-orthodontic with veneers in baby teeth, so canines. Okay, so I'm not worried about it, but it's important to inform your patient. She knows that at any time she can lose that teeth, and she had to make an implant. Okay, in the lower region was harder to assess because I couldn't manage veneers here, because to make everything in the same plane projection, okay, I will have to have a 3 millimeter thickness of a veneer in the 41. So that's not we cannot I make oral hygiene there properly. Okay, so she had this space, and I proposed her to extract one incisor. Okay, to extract one incisor and to put braces for 4 or 5 months in order to align the other 3, and then I could do some veneers. Or I will do the functional treatment with DVO augmentation, but I will do just some composites. The malposition will stay. I will put the incisors with some composite restorations in occlusion with the guidances, and she will stay with the malpositioning. She chooses to make the extraction and maintain the baby teeth. So that's what we did. This is the occlusal upper and the occlusal inferior. And this is the ortho of the case. You can see the canine, impacted canine, the baby teeth, and these are the preparations, okay, with IDS. She had also an erosion factor. I forget to mention. She drinks all day, all the days lemon juice. Okay, so she had grinding and erosion also. And this is the upper veneers. Okay, in this case I do overlays in the posteriors and veneer lays in the premolars and veneers canine to canine. Okay, in the lower I just do veneer lays in the premolars if there's needed volume. Okay, if not, I do just some overlays in the premolars. It's not an aesthetic zone. Okay, so these are the inferior preparations after they align the extraction and the braces. And I had a problem in between the 42 and 43 in the provisional stage. Okay, she was not cleaning it properly, and you will see here. This is the final result. I had to make a canine guidance, a progressive canine guidance, because we lost how do you say it, a central incisor, okay? And you can see she had a very large inflammation there in between the two teeth that I told you, and she lost a little of the papilla, but not a big deal. She was happy with the result, and she's brushing it with an interproximal brush now, okay? And this is the lateral view. You can see overlays in the posterior area and veneer lays upper, premolars, lower, this case overlays, okay? And we did also a crown lengthening of the canine in order to create harmony, okay? Not perfection, but harmony in the smile. And we went, this is the occlusal photo, okay? Upper and lower. And this is the final result. She's a very nice patient. She's a very funny patient. It was a pleasure to treat her. And she's very, very happy. She's a beautiful woman. She has beautiful eyes. And we went from this to this, okay? And she was very happy about it. So this is all I had to you. I hope you enjoyed. I have to thank João. This is João that I spoke all lecture about it. It's a young, very talented Portuguese technician that I work 9 years till now, and I will still go work with him for many years to come if he wants, if he has the patience to put up with me. And I also want to thank my family, because without them I couldn't function, okay? And I take lots of time of them to work and to study and to lecture, and they never complain. So I have to thank them, my beautiful wife, and my beautiful children. And thank you all. Hope you enjoyed it and learned something, and hope you all stay safe with this new situation that we are living with COVID, okay? And these are my contacts. If you want to ask any question, I will reply as soon as possible, okay?
Well, that was a great show, Dr. Philip. I learned a lot, and I bet the audience must have learned the points as well. The weapons are really strong, and we'll try to incorporate all the points you mentioned in our practice to give such beautiful smiles. The cases you showed, the workflow, the team, really amazing.
Thank
And
you.
we are very honored to have you on our platform, and maybe we can have more of your topics later on with more details.
Yeah,
And
we can arrange
yeah,
it if you want to
sure.
put up
From
with me
the
again.
Definitely, why not? The lecture was mind blowing, and from the global summits, I really thank you from the core of the heart of the audience. And any questions will be sent to your email, and whenever there is any time, please answer us back. Though the presentation was very self-explanatory, we really had a great time. I hope the audience learned everything what you said. Each and every line was meant for the good smile of the patient, and especially during COVID times, this knowledge is very much required. Thank you very much, doctor.
Thank you. It was an honor to be part of the Global Summit. Okay.
Cheers. Thank you so much.
Cheers.